Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content from an educational webinar titled Key HIV Studies Influencing My Practice Following IDWeek 2021. During this podcast, Dr. Darcy Wooten, Associate Clinical Professor of Medicine in the Division of Infectious Diseases and Global Public Health in the Department of Medicine at the University of California, San Diego, discusses new HIV data from the STAT and TANGO studies, the TRIO Health HIV Network Study, studies 1489 and 1490, CALIBRATE, and the Positive Perspectives Survey Study. For more information about Dr. Wooten and for a link to the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Wooten has to say about new HIV data from IDWeek 2021.
Thanks so much for that introduction, Sarah, and thanks to CCO for inviting me to come talk today. I'm really excited to go over some of the key studies regarding HIV that came out of IDWeek 2021. Here's an overview of what we'll be covering today. We're going to talk about a couple of studies looking at two drug regimens, including the STAT study, which is looking at using dolutegravir 3TC for rapid antiretroviral therapy. Also, we'll be looking at updated results from the TANGO trial, which looked at switching patients on therapy to dolutegravir 3TC. And then finally, the TRIO Health study, which looked at virologic failure and risk of virologic failure based on whether individuals were switched to a 2-drug regimen compared to a 3-drug regimen. Next, we'll review some of the metabolic complication data that came out of studies 1489 and 1490. We'll go over the lenacapavir resistance analysis that was presented from CALIBRATE. And then finally, we'll talk about a nice presentation looking at patient perspectives on the U=U educational campaign. So let's start with the 48-week analysis from the STAT trial that was presented. The STAT trial was looking at the use of dolutegravir 3TC for rapid antiretroviral therapy in treatment-naive individuals. We know when we're starting patients rapidly on antiretroviral therapy at the time of diagnosis, we often don't have all of their laboratory results back. And so this study looked at 131 patients, starting them rapidly as soon as possible after diagnosis on dolutegravir 3TC. Individuals had labs drawn at week 1 and week 4, and if they were identified as having any of the criteria that would make them ineligible for continuing on dolutegravir 3TC, their regimen was switched to an appropriate regimen. And some of these criteria included having a very low creatinine clearance, less than 30, having chronic hepatitis B co-infection, or having transmitted drug resistance, specifically the M184V mutation. We've already heard about the 24-week data that's been reported from the STAT study, and of all of the participants in this study, 78% were able to achieve virologic suppression, and this included patients with missing data. And when you looked at patients where data was available, 92% of patients in STAT had a suppressed viral load at week 24. So I'll be going over the updated analysis at week 48, specifically focusing in on virologic suppression among those who had an elevated viral load that was very high at baseline. So here are the week 48 virologic outcomes by treatment analysis. And you can see that in each of these analyses, the rate of virologic suppression was quite high, 97% in the observed groups, which are shown in blue. The intention to treat analysis, which is shown in orange and included missing data or counted missing data as failures, still had a fairly high rate of virologic suppression of 82%. And when you really drill down, the non-suppression rate in this analysis was driven not by virologic failures, but a high withdrawal rate. In fact, there were only 2 patients who met confirmed virologic failure. One of these patients had a high baseline viral load greater than 500,000. The good news here is that neither of these 2 patients developed treatment-emergent resistance to either dolutegravir or 3TC. And then for patients who were co-infected with hepatitis B, for whom genotyping data was available, there was no treatment-emergent hepatitis B resistance. So really exciting data from week 48. This drills down a little bit further, looking at rates of virologic suppression when we stratify by baseline viral load and baseline CD4 cell count. And what you can see in the orange box in the middle of the slide is that regardless of baseline viral load, if it was less than 500,000, between 500,000 and a million, or over a million, all of these individuals for whom data was available were able to achieve virologic suppression. And similarly, we didn't see any difference in rates of virologic suppression for individuals who had a low CD4 cell count less than 200. There were 10 individuals who had a viral load that was over a million, and 9 of these individuals remained virologically suppressed at week 48. The one individual who was not counted in this actually developed a rash to dolutegravir 3TC, and so they were switched to a different regimen, and because they were switched, they were counted as a failure. So really nice efficacy data, even at high viral loads when we rapidly start patients on dolutegravir 3TC. Dolutegravir 3TC was very safe and well tolerated. Individuals on this regimen did gain some weight, and that's what we're looking at the figure on the left. Overall, the median change from baseline in weight was about 6.1%. And you can see that the groups that had the most weight gain were those that had an elevated baseline viral load greater than 500,000, or those who had a lower CD4 cell count at baseline. In terms of safety events, listed in the figure on the right are the most common side effects that were observed, and these were, in the vast majority of cases, very mild, grade 1 or 2. So my take-home points from the STAT study is that rapid initiation with dolutegravir 3TC is very effective in achieving virologic suppression in treatment-naive adults when it started via rapid ART. And this was true even for individuals who had a high baseline viral load. There were very few confirmed virologic failures, only 2 patients. So this was a very rare event. And this was not associated with resistance either to dolutegravir or to 3TC. And then we saw the most weight gain in individuals who had high viral loads and low CD4 cell counts at baseline. And this increased weight gain in these groups probably represents a return to health phenomenon. So let's revisit this question that we saw at the beginning. The week 48 analysis of STAT evaluating rapid initiation of dolutegravir 3TC in newly diagnosed adults with HIV showed which of the following? A, virologic suppression was achieved only in those with a baseline viral load less than 100,000. B, virologic suppression was achieved regardless of baseline viral load. C, virologic failure was associated with treatment-emergent resistance to dolutegravir. D, virologic failure was associated with treatment-emergent resistance to 3TC. Or E, unsure. Go ahead and vote. So the vast majority of people participating today, 87%, got the correct answer, which was option B. And to go through this in a little bit more detail, we reviewed that in the STAT study, regardless of baseline viral load, participants were able to achieve virologic suppression. So that makes answer A incorrect. And the 2 patients that did have confirmed virologic failure did not develop resistance either to dolutegravir or 3TC, making option C and D incorrect. So great job, everybody, and thanks for participating. All right, well, let's move on and talk about the week 144 analysis that was presented from the TANGO trial. So the TANGO trial was a multi-center randomized open-label non-inferiority phase 3 study looking at individuals who were suppressed on antiretroviral therapy, either a 3 or 4 drug TAF-based regimen. And participants were randomized to either switch to dolutegravir 3TC or to continue their current regimen with TAF. Important exclusion criteria for this study were that individuals could not have had a history of prior virologic failure, they could not have any resistance to NRTIs or INSTIs, and no hepatitis B co-infection. And we've already heard about the week 48 and week 96 FDA snapshot data, which showed that dolutegravir 3TC met the primary endpoint of non-inferiority in terms of maintaining virologic suppression. And so the current analysis extends out to week 144, looking at not only virologic outcomes, but also weight, metabolic, and other parameters. So here's the week 144 virologic outcomes data by FDA snapshot. And you can see that in blue were the participants who received and were switched to dolutegravir 3TC, whereas the orange include the individuals who were continued on their TAF-based therapy. And in terms of the primary outcome of virologic failure, you can see that rates of failure were very, very low in both groups. Similarly, rates of virologic success were high in both groups, and there was no statistically significant difference between these two groups. There were 3 cases of virologic failure overall. 0 were in the dolutegravir 3TC group, and 3 were in the TAF-based group. These 3 in the TAF-based group did not develop any NRTI or INSTI-associated resistance at the time of failure. And interestingly, there were 7 participants who were identified as having pre-existing archived M184 mutations. 4 of these in the dolutegravir 3TC group and 3 of these in the TAF group. All 4 in the dolutegravir 3TC group were suppressed at week 144. These tables show changes in weight as well as changes in metabolic biomarkers from baseline to week 144, comparing those who are switched to dolutegravir 3TC compared to those who were continued on their TAF-based therapy. And you can see that individuals did gain a small amount of weight in each group. This gain in weight was small and was not statistically significantly different between the 2 groups. One notable difference was in individuals who were obese at baseline. Those individuals who were in the TAF-based arm were more likely to be referred for weight management, diet and exercise counseling, compared to individuals who were obese at baseline and randomized into the dolutegravir 3TC arm. In terms of fasting lipid changes, the dolutegravir 3TC arm did show a more favorable profile in lipid differences from baseline to week 144 compared to the TAF-based arm. These numerical differences were small, and it's unclear sort of how clinically significant this is, but there was a statistically significant difference. And here we see the changes in renal and inflammatory biomarkers between these 2 groups from baseline to week 144. And what we're seeing here is that these changes in renal biomarkers and inflammatory markers were quite small, and in the vast majority of comparisons were not different between the 2 groups. So my take-home points from the updated 144-week analysis of the TANGO trial is that switching to dolutegravir 3TC was quite effective in maintaining virologic suppression in these treatment-experienced individuals. The lipid changes generally favored dolutegravir 3TC, and then inflammatory marker changes were fairly minimal and similar between groups. Weight gain and weight change was similar between dolutegravir 3TC and the TAF-containing group. So there was no benefit in terms of weight stabilization or weight loss with the dolutegravir 3TC arm. All right, and then we'll move to talking about the TRIO Health HIV Network Research Study. This was a retrospective observational study that used electronic medical record data from the TRIO Health HIV Research Network, which is a cohort in the United States of over 60,000 people living with HIV. And this study included nearly 2,000 individuals who were living with HIV and suppressed on their current regimen. And the investigators looked to see individuals who were switched to a 2-drug regimen compared to individuals who were switched to a 3-drug regimen, whether this had any impact or predicted subsequent virologic failure. So all of the participants had to be virologically suppressed at the time of switch. You can see that the 2-drug regimens that individuals were switched to in the study were dolutegravir 3TC, which is shown in dark blue, and dolutegravir rilpivirine, which is shown in light blue. And you can see that there were much smaller numbers of individuals who were switched to 2-drug regimens compared to those who were switched to 3-drug regimens. And the most common 3-drug regimens that were analyzed included those who switched to bictegravir FTC TAF, which is shown in green, which was the most common regimen at switch, and dolutegravir abacavir 3TC shown in orange. So I think it's important to review some of the baseline characteristics of this study, since these weren't randomized controlled trials. It was observational data, and there were some differences in the baseline characteristics. Specifically looking at race, Black race was less likely to be switched to a 2-drug regimen compared to a 3-drug regimen. And similarly, there were more white individuals who were switched to 2-drug regimen compared to a 3-drug regimen. Another notable difference is that a lower EGFR was much more commonly seen in individuals who were switched to a 2-drug regimen compared to those who were switched to a 3-drug regimen. And then other differences not shown in the table are that individuals who were switched to a 2-drug regimen were less likely to be receiving a booster and more likely to be on an NRTI or NNRTI sparing regimen. So here we see the results looking at risk of virologic failure as well as time to virologic failure based on whether individuals were switched to a 2 versus a 3-drug regimen. And on the left, we're seeing the unadjusted analysis with 2-drug regimen being shown in blue and 3-drug regimen switch in orange. And in the unadjusted analysis, there was no statistically significant difference in terms of risk of virologic failure or time to virologic failure. And the rates of failure were low overall, 7% in the 2-drug arm and 4% rather in the 3-drug arm. However, when we look at the adjusted analysis, which is in the figure on the right, we see that after adjusting for race, gender, age, and baseline EGFR, there actually was a difference, and the risk of virologic failure was almost 2 times higher in the 2-drug regimen, individuals who are switched to a 2-drug regimen, compared to those who were switched to a 3-drug regimen. The investigators tried to control for baseline CD4 cell count, but this wasn't possible in their analysis because there were too many participants who had missing CD4 cell data, probably because of updated guideline recommendations that makes monitoring CD4 cell count optional in certain clinical settings. So my take-home points from this study are that this represents a real-world population analysis, which shows that there is a higher risk of virologic failure when switching patients to 2-drug regimens compared to 3-drug regimens after we adjust for some of these baseline characteristics. I do want to point out that this is a very different finding than what we've seen in the randomized control trial data that looks at switching suppressed individuals to these 2-drug regimens. And the randomized control trial data has not shown that there's any increased risk in virologic failure with these 2-drug regimens. So how do we reconcile these two different findings? And I think it's important to think that the results in this observational study could have been influenced by various factors, including potentially patients who are receiving 2-drug regimens in this real-world scenario are different than those who received 2-drug regimens in the clinical trials. It's also been well documented that adherence is not as good in the real-world setting compared to clinical trials, and this may be explaining some of these discrepancies. And then finally, in this observational study, there are multiple patient factors, such as past resistance data that wasn't known and couldn't be accounted for. So definitely something to think about in terms of when we're thinking about switching individuals to a 2-drug regimen and really making sure that those patients are ones who really met the criteria that would have been required for those randomized control trials showing the efficacy of 2-drug regimens. All right, well, now we'll change gears a little bit and talk about some updates on metabolic complications that were reported in studies 1489 and 1490. So these were 2 parallel randomized double-blind placebo-controlled trials with bictegravir FTC TAF. In study 1489, individuals were randomized to either receive bictegravir FTC TAF or dolutegravir abacavir 3TC. And I should clarify that these were treatment-naive patients. In study 1490, treatment-naive individuals were randomized to either receive bictegravir FTC TAF or dolutegravir plus FTC TAF. And so they looked at week 144 at metabolic complications between the different regimens, including treatment-emergent diabetes, treatment-emergent hypertension, BMI changes, and lipid changes. It's important to recognize and remember that the mean age in both of these trials was quite young, in the early 30s. And so the likelihood of participants going on to develop these metabolic complications after being on antiretrovirals for 3 years is just something to keep in mind. So this table shows the outcomes in terms of metabolic complications in these 2 studies with 1489 on the left and 1490 on the right in terms of treatment-emergent diabetes, treatment-emergent hypertension, and median BMI change. And you can see that the rates of these metabolic complications were low overall, and not statistically significantly different between the different regimens. Similarly, we didn't see any significant differences when stratified by sex assigned at birth or when stratified by race, either Black versus non-Black. Changes in fasting lipids were fairly rare, and the requirement to initiate lipid-lowering therapy was very low across the entire study populations, less than 3%. There was one small nuanced difference that I wanted to talk about in terms of change in BMI from study 1489. We did initially see a greater increase in BMI in the BIC-F-TAF group compared to dolutegravir/abacavir 3TC at week 96. However, this difference went away at week 144, suggesting that there wasn't any long-term association with weight gain and the specific regimen. And then these figures show BMI categorical shifts from baseline to week 144, so meaning how many individuals went from being overweight to obese or went from being obese to morbidly obese. And we see study 1489 on the left and study 1490 on the right. And what you can see from baseline to week 144 is that there was no significant difference in BMI categorical distribution, looking at treatment regimen or when stratifying by sex at birth or race. So take-home points from these two studies is that there's really no significant difference in these metabolic outcomes, including treatment-emergent diabetes, hypertension, and BMI changes between bictegravir FTC-TAF, dolutegravir FTC-TAF, and dolutegravir/abacavir 3TC. And really the data support that these are first-line regimens and that they have long-term safety, at least over the 3-year period that these were studied. Okay, so now we'll move on to talking about the resistance analysis that was presented from the CALIBRATE study. So the CALIBRATE study is a randomized open-label phase 2 trial looking at the use of lenacapavir in combination with other antiretrovirals for the treatment for treatment-naive people living with HIV. And lenacapavir, as you'll recall, is a new-in-class capsid inhibitor, and it has very unique PK properties in which it can be given subcutaneously every 6 months. So in CALIBRATE, individuals were randomized to one of 4 groups, and there was an induction period and a maintenance period. So individuals in group 1 received an oral lead-in phase with lenacapavir, and during the induction phase were switched to sub-Q lenacapavir given every 6 months along with daily oral FTC-TAF. At week 28, they were switched to the maintenance regimen, which was len sub-Q given every 6 months, along with daily oral TAF just by itself. Group 2 included individuals who received an oral len lead-in phase and then received subcutaneous len every 6 months during the induction phase, along with daily oral FTC-TAF. At week 28, they were switched to their maintenance regimen of subcutaneous lenacapavir given every 6 months with daily oral bictegravir. Individuals in group 3 received daily oral len plus daily oral FTC-TAF for the duration of the study, and group 4 received daily oral bictegravir FTC-TAF for the duration of the study. So here we see the week 28 virologic outcomes by treatment group via FDA snapshot, and you can see that rates of virologic suppression were very high among all of the treatment groups, and they were not statistically significantly different between these groups. In the figure on the right, we see the viral kinetics, and you can see again in all 4 groups, individuals had achieved rapid virologic suppression, with upwards of 80% being suppressed by week 4 in all of the groups. So here we are looking at the baseline and week 28 resistance analysis that was done in this study. And you can see that all individuals in this study underwent baseline resistance analysis to our common antiretrovirals that we look at when we're doing genotypes, including NNRTIs, NRTIs, and PIs, but also integrase inhibitors, as well as lenacapavir resistance. Not surprisingly, NNRTI resistance was the most common at baseline, but of note, there was no transmitted drug resistance to integrase inhibitors and, not surprisingly, no lenacapavir resistance. There were 3 individuals who met criteria for undergoing resistance testing at week 28, and there was 1 individual from each of the lenacapavir-containing arms. An individual from group 1, as well as an individual from group 3, achieved virologic suppression and then had viral rebound, And this is when they underwent resistance testing. They did not have any lenacapavir or other resistance, and they were able to resuppress on their study regimen. The individual in group 2 is a different story, and they were started on their regimen, but never achieved virologic suppression. And that individual did go on to develop resistance. And I'm going to talk a little bit more in detail about that on the next slide. So this shows the mutational profile of this patient from group 2 who did go on to develop resistance. You can see in the dark blue line that their baseline viral load was about 100,000, and you can see that that viral load dropped during the initial oral lead-in phase with lenacapavir. But then at week 2, they had this steady rise in viral load until week 10, at which time they met criteria for suboptimal virologic response. And so genotyping was done at that time at week 10, and that's shown in the pink box. And there were multiple mutations noted, including 2 capsid mutations, the Q67H, as well as the K70R, and an NRTI mutation, M184MI. The investigators then went back to see when did these resistance mutations develop. And they used a different next generation sequencing assay, which was able to detect resistance mutations down to 2% of the population. So you can see in the blue boxes at baseline, there was no capsid mutations and no NRTI mutations. However, at 2 weeks, we see the emergence of NRTI resistance with the M184I and the M184V. And then by week 4, we see the development of the first capsid resistance mutation, the Q67H. This patient did go on to change their regimen with a dolutegravir-containing regimen, and they were able to achieve virologic suppression. But what's really interesting about this case is that this patient did not have any missed doses of either oral len during the lead-in phase or the subcutaneous administration of the lenacapavir. And then when plasma concentrations of len were measured, they were always in the target range. Similarly, when this individual had plasma FTC and tenofovir concentrations measured, these were at the expected range as well. So what we see here is that the NRTI resistance mutations developed first, and then we saw emergent lenacapavir resistance mutations develop afterwards. And it's not totally clear why this person developed resistance. The study investigators hypothesized that it's potentially because of non-adherence to the daily oral FTC TAF when the patient wasn't getting directly observed therapy, but that's just the hypothesis. So take-home points from the resistance analysis from CALIBRATE include the following. Lenacapavir and FTC TAF result in high rates of virologic suppression, and these are similar to what we see with bictegravir FTC TAF. There was only one patient who developed virologic failure, and they first developed NRTI resistance, and then this was followed by capsid inhibitor resistance. Again, unclear why this patient developed resistance because they had no missed doses and therapeutic levels of lenacapavir. So now we'll return to the second question, which we saw earlier at the beginning of the presentation. In the week 28 interim resistance analysis of CALIBRATE, evaluating long-acting lenacapavir in treatment-naive people with HIV, treatment-emergent lenacapavir resistance was not observed, B, present in those with some lenacapavir resistance at baseline, C, preceded by NRTI resistance mutations, D, associated with subtherapeutic lenacapavir concentrations, or E, unsure. Go ahead and vote. All right, you guys did a great job, and it looks like 70% of people got the correct answer, which we'll review right now. So the correct answer was C, lenacapavir resistance was preceded by NRTI resistance. Option A is incorrect because lenacapavir resistance was not commonly observed. It was only in one individual. We also saw from the baseline resistance analysis that there was no lenacapavir resistance at baseline, so this did not impact the subsequent development of resistance. And finally, option D is incorrect because the patient who did develop resistance had target level lenacapavir concentrations, and it was not because of subtherapeutic concentrations. All right, so we'll finish up by discussing a nice study looking at patient perspectives on the impact of the U equals U educational campaign. So U equals U, as I'm sure everyone is aware, was initiated in 2016 in multiple different countries with a number of goals and objectives, including to improve the quality of life for people with HIV, as well as to encourage uptake and adherence to treatment, and really to reduce HIV-associated stigma. And the key messaging in U equals U, which we're all familiar with, is that people with HIV who are on treatment and are able to achieve and maintain virologic suppression are not able to transmit HIV to their sexual partners. And there have been a number of studies which have demonstrated the benefits of this messaging. So this was an updated positive perspective web-based survey that was done across 3 countries in Canada, Mexico, and the United States, looking at how U equals U education and counseling impacted individuals living with HIV. So here we see the proportion of individuals participating in the survey stratified by country in terms of how many reported that their healthcare provider told them about the concept of U equals U. And you can see that 55.8% of individuals in Canada, 60.3% in Mexico, and 70.8% in the United States reported that their healthcare provider had talked to them about this. You can also see the self-reported optimal adherence as well as sharing of HIV status to somebody besides a healthcare provider in these different countries. What I think is really important that came out of the study is that whether or not somebody received or reported receiving U equals U education really varied by a number of different characteristics. So sex, sexual orientation, and then location. So if you were male sex assigned at birth, you were less likely, at least in the United States, to report having received U equals U education. If you identify as heterosexual in the United States, you are less likely to report receiving this education or counseling. And then finally, in the US, if you lived in a non-metropolitan area, you were less likely to report that you had received this education. Interestingly, year of diagnosis, so either before the U equals U campaign was launched or after, did not impact whether or not people reported receiving U equals U counseling. And so when we look at health outcomes and treatment perceptions among individuals, we see that U equals U, again, in the United States, really had some positive benefit. So of those who had received U equals U counseling, they were more likely to report being virologically suppressed, more likely to report optimal mental health, and more likely to report optimal sexual health. We didn't see statistically significant differences in Canada and Mexico in these parameters. Also in the US, we saw that individuals were more likely to report that they were satisfied with their treatment and that they believed that treatment prevented transmission if they had received U equals U counseling. So my take-home points from this US-based population study is that conveying U equals U to our patients really does, at least in the United States, positively affect their self-perception of physical, mental, and sexual health. And these are really important in terms of improving outcomes and quality of life for people living with HIV. I also think it's important to remember that there are some groups for whom our messaging is not coming across. And so we need to continue to get that message out and work on strategies to ensure that all groups are getting this important message. So with that, I'd like to thank you for your attention and like to turn it back to Sarah to open it up to the question and answer session.
Thank you so much to Dr. Wooten for that excellent presentation. We've had a number of questions from participants and appreciate all of the engagement, and we will do our best to answer as many as we can in the time that we have left. So my first question is from Sebastian, who asks about the STAT trial. Do you see a reason or an advantage of using dual therapy up front in rapid starts instead of starting triple therapy and then switching 1 or 2 months later when you have more results?
Thanks for that question, Sebastian. I think that is a great question and a very kind of practical question that I've been thinking about in my mind. I think at this point, there's not necessarily an obvious advantage in the data other than just the idea that you're starting fewer medications as opposed to 2 medications versus 3 medications, which so far we haven't seen any large hard outcome benefits to, but over time might prove some benefit, especially as we get more data looking at association with weight gain and TAF compared to TDF. So I think there's not a tremendous advantage, and you do run the risk if you rapidly start somebody with dolutegravir 3TC and they come back with criteria where they can't continue on that regimen, like hepatitis B co-infection, that then you have to change their regimen, and sometimes that can be disruptive to patients. But for other patients, that might not be as big of a deal, and some patients might prefer to be on fewer medications as opposed to more. And I think what's nice and reassuring is that we were able to achieve, at least in this preliminary analysis, high rates of virologic suppression.
Wonderful, thank you. We had similar questions from other participants, so that seemed like a hot topic to cover. So thank you for addressing that. Our next question comes from Timothy, who asked, based on the results of the TANGO study, what patients are you switching to the 2-drug regimen?
So again, that's a great question. And I think also, and I'm going to try and answer that question in the context of the data that we saw from that third study that I presented from the TRIO Health data, which showed that when you do switch to a 2-drug regimen, you might be putting people at higher risk for virologic failure, although we talked about some of the limitations in terms of interpreting that data. So individuals that I'm switching to dolutegravir 3TC are individuals where you might not be able to use tenofovir, or if they're on dolutegravir 3TC abacavir, and they've been virologically suppressed, really that abacavir probably isn't doing very much. And we know that there's mixed data showing increased cardiovascular risk with abacavir. So that seems to be a fairly easy switch. And then again, as I alluded to before, as we think about weight gain and metabolic complications with not only our second generation integrase inhibitors, but also TAF in comparison to abacavir and TDF, if I'm concerned about weight gain in a particular patient, or I have a patient who's experienced a lot of weight gain, that's where I might think about switching from a variety of different regimens. Although so far, the data in terms of weight differences, switching to dolutegravir 3TC did not seem to have any beneficial effect in terms of leading to less weight gain or weight loss. So drug-drug interactions, weight are things that I'm thinking about, and sometimes renal function as well. I think that is a nice 2-drug regimen to switch to the dolutegravir 3TC, because you still have that really high barrier to resistance with the dolutegravir.
Great. Thank you for providing that answer as well. It seems like it's top of people's mind when we're thinking 2 drugs versus 3 and 4 drug regimens. So switching gears just a little bit, a question came in from Sebastian on the CALIBRATE study. Do we know yet if there is a fitness cost associated with the Q67H and K70R lenacapavir resistance mutations?
That is a great question. And I don't know if that is known. I personally don't know that. And I would make the assumption, but again, I want to just put the caveat out there that I'm not 100% sure that there might be, given that we didn't see any baseline resistance, but that in no way guarantees the answer to that question. But I suspect there might be, but I think it's something at least that I would need to look more into, and that probably is still being investigated.
Great, thank you. And given all of these data put together, we had a lot of exciting data come out on HIV-related therapeutics during IDWeek. What do you feel like is the most compelling data that you feel like will impact your practice?
It's such a good question. I mean, I think there's a number of things that we've talked about. For sure, the data showing that regardless of viral load, we were able to, at least in the STAT study, achieve virologic suppression with dolutegravir 3TC and not have any virologic failures and no failures with resistance is sort of additional evidence and support, and makes me feel better in terms of having that be a very robust regimen in terms of barrier to resistance. So I think that definitely is very reassuring. I think the data in terms of metabolic complications from the 2 parallel studies that I presented also don't necessarily change my practice, but sort of reaffirm this idea that there's probably not a lot of difference between bictegravir FTC TAF and dolutegravir FTC TAF. And so when I'm trying to choose between those 2 regimens, I'm not going to be influenced by concern about metabolic complications. because the metabolic complications from those two regimens seems to be fairly similar. And so in choosing between those two regimens, I would think about, does this patient really need a single tablet regimen option? Are there drug-drug interactions that favor using dolutegravir over bictegravir, for example? But just sort of, again, kind of nice to see the data that dolutegravir and bictegravir are very similar. It's sort of, I think, an assumption that we've been making, and that there's other data to support that. But this really solidifies that. And that's sort of nice to be able to have a very well-designed randomized controlled trial data to demonstrate that.
Great. Thank you for sharing that. And I think in our last minute that we have left, one last question comes to us from Mallory, who asked, how do you balance the benefits of the U=U messaging with the ongoing increase in sexually transmitted infections?
It's such a great question, and definitely something that I feel I struggle with many patients that I see each day in clinic. I think it's kind of a both and not an either or. So I think the U=U messaging where I've really seen how beneficial it is really for individuals that have self-stigma and so much shame. And this contributes to mental health issues and lack of self-efficacy. And then, kind of as we go through this concept and counseling about U=U, and they don't feel like a disease, they feel like a person, I really see a change in them. At the same time, I think as we kind of continue to get that message of U=U out, we still have to link that messaging simultaneously. You can still acquire other sexually transmitted infections, including syphilis, gonorrhea, chlamydia, et cetera, and talk to our patients about how to best protect themselves against those infections. So I think kind of coupling those messages together and seeing sort of the different benefits in terms of the individual sort of self-efficacy benefit, but then also trying to keep that public health perspective in mind in terms of increasing rates of STIs, which are, of course, a challenge.
Thank you very much to Dr. Wooten, and thank you to our listeners for joining in. As a reminder, to view the full IDWeek 2021 conference coverage program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.